All right, so this is a continuation of the postoperative complications. We already mentioned a lot of those different things, which would include diaphragmatic breathing, coughing and deep breathing, leg exercises to prevent DVT formation, as well as turning side to side or turning to the side and offloading the pressure to decrease offload the pressure. So we are going to be looking at coughing and deep breathing. We're also going to be looking at turning them side to side to offload that pressure. And so repositioning is extremely important, making sure that they are changed in positions. Every 2 hours is recommended to sort of turn positions. Getting out of bed, making sure that they're ambulating as early as possible. Again, to prevent things like atelectasis or to prevent DVTs, and then incentive spirometry as well. Okay, to promote that lung expansion to happen. Pain assessment is crucial to do. We can use a variety of different scales if we are using FLACC, which is a face, legs, arms, things like that. You can use that kind of scale as well, or you can use the 0 to 10 scale as well. Different sort of things that you're thinking about. Orthopedic surgery, we remember that we do need, after orthopedic surgery, they might be transitioning to a lower level of care. So we're thinking short-term rehab or things such as a long-term care as well. So those are some of the things that we want to keep in mind. So those referral, remembering that transition plan as well as that discharge planning should be happening as well. Remember with knee replacements, we want to look at going in and kind of looking at what we can do to kind of prevent any postoperative complications. Remember, the goal is for the client to have the ability to bend the knee 90 degrees by discharge. So they should be able to go a full 90 degrees, which means obviously they're going to be able to flex their knee. And oftentimes, if they're on a CPM, which is a continuous kind of passive range of motion machine, which actually moves that joint for you, they should be the amount of flexion for clients with hip replacement should never exceed 30 degrees. So they should not go past 30 degrees in a continuous passive machine. So clients should be up and walking with walker and performing prescribed exercises as well. So 30 degrees, no more than that. Amputation, we are looking at several different types of amputation. And one of the most common reasons why you could possibly have an amputation is due to the fact that there is something such as a malignant tumor or diabetes, okay? Diabetes, which leads to diabetic ulcers, which then lead to gangrene, and then which then lead to like trauma and things like that that can affect that region, okay? Life-threatening disorders, infection, all of that. Remember, treatment for disorders influence healing. Level at which limb is amputated also is where it's going to affect the healing as well. Remember that one of the things that you would look at is if they have a BKA or an AKA. BKA would refer to below the knee amputation. AKA would be above the knee amputation. So it's good to be familiar with that terminology. Remember, after an amputation, you're monitoring for signs and symptoms of infection. Remember, if you are wrapping that leg, you would technically go in a figure 8. So when you're wrapping up that stump, it would be a figure 8 kind of wrap, circle wrap that you would do. And that's just to kind of promote the best healing for that leg, as well as to make sure that we don't get any sort of stump does not form abnormally. Prosthetic fitting can be done, but we definitely have to wait for that wound to heal before they can be fitted for prosthetics. And of course, if they have above the knee or below the knee, regardless, you are going to be helping them to do at least passive range of motion or like flexion of the hips to make sure that there's no contracture formation. If they have things like a below the knee, BKA, below the knee amputation, you will be working on moving that knee joint, because a below the knee amputation is done below the knee joint. So that's what you'll be looking at, BKA. And here is attachment of a temporary shell, prosthesis to plaster shell, custom-made conventional prosthesis. Prosthesis fittings do take some time. It is not quick. It does take some time to happen. Keep that in mind. One of the things that you can have after amputation is phantom limb or phantom pain. And most of the time with phantom pain, it is that it's almost the feeling of that leg is still there and the nerve's trying to kind of communicate with that leg. And it can be very severe pain that they experience with the phantom limb pain. And medications that can be given to treat this, surprisingly, are going to be your antidepressant medications can be used, beta blockers can be used, anticonvulsant medications can be used. So a variety of different medications can be used, but phantom limb pain is a classic sign of this painful kind of stabbing, shooting pain that can occur as a result of amputation. Okay. As a result of amputation is what you will see. Nursing management is what we're looking at in terms of that. Here is nursing care, planning and interventions. You want to encourage, you really do want to encourage them to prevent disuse syndrome related to altered mobility. So to prevent that disuse syndrome from happening, your goal is to make sure that they are getting some movement, at least passive range of motion, to prevent muscle atrophy from happening. Provide stem care and bandaging, ensure proper positioning. So after a knee amputation, proper positioning would be looking at kind of making sure that you don't keep your residual limb flat so that your hip and knee are straight. You want to kind of keep them in a supported position, but you don't want it to be completely in a, I should say completely in a flex position. You don't want it to be in a completely flex position. So I'm sorry, on the contrary, you don't want the limb to be completely flat. You want it to be in a supported position. You do want to make sure that they are getting some passive range of motion. And you want to make sure that you keep the residual limb flat. So you don't want it completely flat. You want to keep it flat at least for 30 minutes twice a day to make sure that it doesn't go into that kind of bend positioning. So you do want some of that flatness happening, but only for about 30 minutes or twice a day, ideally. And that's recommended. Now, we are concerned about proper nutrition to promote kind of healing of that stump care. And then expect the client with the prosthesis to progress to walking and providing assistive devices. For this patient, all throughout that plan, they will be working with a PT and or OT. Okay, amputees receive prosthesis soon after surgery. Like I said, it really depends. Sometimes it does take some more time depending on what kind of insurance you have. If it's more Medicare or Medicaid, it's going to take some time, to be quite honest. And rehab team begins as a team approach. So rehab will be working with them to help them, assist them throughout this procedure. This is a case study. We don't need to worry so much about that, but we are now going to jump into your crutch walking and your different gaits. So when you're looking at crutch walking, there is some basic things that we need to remember in terms of crutches, right? So crutches, there's two of them, right? It's not just one. And we have to have them properly fitted. And this is another crucial point. Remember, there should be a 2 to 3 finger width gap. There should be a 2 to 3 finger width gap between. There should be a 2 to finger width gap between their axilla and the actual crutches. So that's extremely crucial to have. Remember, you are placing your weight on the hand grips, not the crutch rest pads. Your weight on the armrests, and this is extremely important to know. Okay, these are the kind of those questions that you get, and you just need to know what's appropriate and what's not. And remember that the elbows should be flexed at 30 degrees. The elbow should never be completely flat. So we should see a 30-degree elbow flexion when they're holding onto those crutches, when they're moving with those crutches. It should never be completely flat. A 30-degree flexion, you're imagine if you look at my arm sort of like this, okay? So not completely bent, but there should be a slight bend in that. The next thing that we're assessing is for sort of the type of gait that they need, okay? Remember that the crutch needs to be 6 inches to the front of you, and it's not going to be completely straight in front of your feet. It's going to be off to the side a little bit. And this is known as a tripod positioning. So it should be about 6 inches diagonally. So 6 inches diagonally in a tripod positioning. So it should not be completely in front of your feet. It should be slightly off to the side. Can't spell today. Diagonally. Okay, 6 inches diagonally is what you will be seeing. The other thing to kind of keep in mind with this is that we have to assess on how they can walk with those crutches. So there is a 2-point gait with a crutch, and with the 2-point gait is that the patient will move the injured side's crutch. So whatever side is that injured side, that's going to move at the same time as the non-injured leg. So for example, say that my right leg is injured, so 2-point gait for crutches. So say my right leg is injured, the crutch on my right leg is going to move at the same time as a non-injured leg, and then it will be the non-injured leg and the non-injured leg and the injured leg and the non-injured side's crutch together. So now this can be really confusing. So here's, I'm gonna kind of break it down. So say your right leg is injured, okay, and you've got crutches, right? One on the right and one on the left. So if your right leg is injured, you're going to move your crutch on the opposite side. So crutch on the left leg. Oh, no, my apologies. Crutch on the right leg, the injured leg, right? Let's say injured. And the left leg, the non-injured leg together. Okay, so you're going to move them together. So at all points, you've got at the same time, you've got 2 points moving at the same time. Then you're going to move the opposites. So just think the easiest way to remember is opposites move together, starting with your crutches and the non-injured. So non-injured stuff is going to move first, okay? Followed by the injured. So it's always going to be non-injured, so you have more of a support, and then it's going to be followed by your non-injured or your injured leg. Now we do have the 3-point gait as well for your crutch walking, and so actually not the 3-point. Excuse me, you won't have the 3-point. It's more you can have the 3-point, but the 3-point is where you're obviously not letting the injured leg touch the ground. So the 3-point crutch gait is going to be where you move both the crutches and the injured leg forward. So I want you to think about 3-point gait as that gait when the patient is basically hopping, right? You've got that, you're holding up the injured leg. And what you just do, this is the most common one that we associate with. You have the person, the crutches move together first, okay? Move together in front, and then followed by your good leg. So that's 3-point gait. Okay, you're gonna move those crutches forward together, followed by your good leg. And obviously you're holding up that injured leg together. Now, the 4-point gait is going to be where this is the type of gait which is similar to the 2-point gait, but the crutch and the leg move separately. So the 4-point is that every single piece is moving at different points, right? The reason why we say 2-point gait is that when 2-point gait, 2 things are moving at the same time. At 3-point gait, you have basically all 3 things sort of moving together, like your crutches and your injured leg moving at the same time. You're holding up the injured leg, so you're assuming it's moving together with those crutches. And the 4-point gait, though, everything is going to move separately. So with the 4-point gait, remember, with the first thing, and I'm going to see if I can even actually make this a little bit smaller. It's also already pretty small, but let's zoom in. So with the 4-point gait, remember, this one is, so I'm going to kind of walk through it first, right? Remember, everything is moving separately. So what moves first? So you're going to move the right. So say that my right leg is injured. So that crutch, not the leg, the crutch is going to move first, and then it's going to be the opposite, and then it's going to come back. And so it's going to then come back to the right leg. So it's going to be every piece is moving separately. So first, again, just to reiterate, say your right leg is injured, so that right crutch is going to move forward, followed by the left leg, the good leg, followed by the left crutch, and then your injured leg. So your injured leg is always going to go last. Okay, so we say the right leg is a bad leg. So crutch of bad leg, followed bad leg, followed by your you're gonna move the left leg, followed by the good leg, the crutch of the good leg, and then the good leg, the crutch of the good leg, and then the bad leg. Okay. And then the bad leg is going to be the one that's going to be moving. So every piece is moving separately. So just to reiterate, I'm going to pull up a picture at this point. So just a kind of a good way for you to remember and or recall this. So with your 2-point gait, see, it's very hard to sometimes find an appropriate, like a really good picture, unfortunately, because those pictures can be really confusing. So here's what I can pull up really quickly here. This is going to be the 2-point gait. With the 2-point gait, what you are seeing on here is that you actually have, so again, just to reiterate, the 2-point gait, got a person holding all the crutches, remember 2 to 3 finger breaths, and what you will see is that they're having a 30-degree flexion of that elbow, and they're holding up that leg or holding up that position. You will see, again, just to reiterate, with the 2-point gait, they're moving 2 things at the same time. So with the 2-point gait, if you can see on here, let's see which one of our legs. So we're not really sure which one of our leg is injured. So we're going to assume it's the right. It's going to be the right leg, okay, which is going to be injured. So you're going to move the crutch on the injured leg first, just the crutch, and then the left leg together. So opposites are going to move together, starting with the crutch on the injured leg, then followed by your injured leg and the good crutch. Okay, that's your 2-point gait. Just remember opposites moving together. 3-point gait, easy enough to remember, right? With your 3-point gait, this is typically the most common one that we associate 3-point gait. I really like this picture for 3-point gait. This is a pretty good picture. This is what it looks like. 3-point gait, as you can see, they're not really putting any weight on that right leg. So they're basically moving your crutches together, okay? And crutches together at the same time. And you can actually kind of slightly move your good leg forward, and then it's going to be sort of followed by that bad leg, and you can then put your leg down, basically. So really putting all your weight on that crutch, right, while you're holding up that leg, and then you move that leg, and then you move your good leg forward, and then followed by that injured leg. Now the 4-point gait, again, everything is moving separately. So you start with the crutch of the bad leg, just like how you do for the 2-point gait. It starts the same way. The crutch of that bad leg, followed by the good leg, is what you're going to do for the 4-point gait, then followed by the crutch of the good leg, and then the bad leg. All right, so those are the different types of gaits that we are going to be exposed to. And what about when you're going up the stairs and going down the stairs? So mnemonic to remember is good, go to heaven, bad, go to hell. So good, go up to heaven, and bad, go down to hell. So what this mnemonic basically means is that when you're going up the stairs, the patient is going to move their good leg up onto the step first, because you need to balance, you need some good support, right? And then it's going to be followed by the bad leg and the crutches. Okay. So when you're going up the stairs, good leg first, followed by crutches and bad leg. Okay. Same thing with your, when you're going down the stairs. When you're going down, you're actually going to do the opposite. Your bad leg is going to go down first, right? So you're going to move the crutches down first, obviously, because how else are you going to support yourself? And then the bad leg, and then the good leg. So, okay, so crutches, okay, bad leg, and then good leg. And some of this is just sort of thinking about common sense and saying, which one makes sense for me to give me the most support? Because if I move my crutches and bad leg down, I'm still having weight on that good leg, so then I can just follow it up by that. But my bad leg is going to be supported. So kind of a good way to remember this, right? Good go to heaven, bad go to hell. Nothing else that's really important, the positioning and everything. When they have a walker, right? If they have a walker, remember that the walker, where they're holding the handle of that walker should match up with your wrist crease. So wherever your wrist crease is, that's where that walker is going to match up. Okay. And again, there should always be that 15 to 30 degree flexion. 15 to 30 degree flexion is extremely crucial for these individuals. 15 degree flexion when they have a walker as well. Remember with walkers, I've seen a lot of patients do this. They will have their walker in front. Remember, you should be walking into the walker. The walker is a support mechanism. The patient should be making sure that their middle of their foot should be lining up with the back tips of the walker. So the back of that walker, the walker has got like four, again, just a little bit of visual imagery here. The walker, so the back of that walker should be lined up with the middle of the person's foot at starting position. That tells you that you're either not too far in and you're not, so here's what you'll see. Okay? Here's what you'll see. You will see that you don't want to walk too far in there as well. And so what you will see is that the middle of the foot lines up with the back tips of the walker. Right? Remember, the patient will lift and move the walker forward. They will need to lift, especially those walkers that don't have the wheels. You will need to lift the walker and move the walker forward, which means that the patient needs to have good upper extremity strength to be able to do that. If they don't, then they probably will not be eligible for the use of a walker. So they will need to lift and move the walker forward. They will need to make sure that all four tips of the walker legs are touching the ground after moving the walker. Don't pick up the walker and don't lift the walker and walk at the same time. You lift the walker, move it forward, and then you walk into it. And remember, you put weight on the hand grips you put the weight on via the hands. The patient will move the strong side forward. So whichever leg is strong, you will, or whichever leg is weak, whichever leg is weak, you will move that weak leg forward, followed by the strong. Because when you move that weak leg forward, just think about the walker as having a support. Okay, you're having a support for the walker. So then, when you lift up, the patient will lift and move the walker forward. Then they will move the weak leg forward, and then they will be followed by the strong leg. Whenever they're getting up, sitting down, and getting up from a chair, right? You're going to push up. Okay, you're going to push up from the walker until they feel the chair with the back of their legs, and then you're going to. So if you're getting up from a chair, you're going to push up with your arms, or you can have a positioning where you have one hand placed on the walker and then one hand on whatever surface you're pushing from. You never place both hands on the walker. That is when patients are going to fall backwards and they're going to tip backwards on there. All right. Cane walking is the last thing that we're going to mention here. And with cane walking, remember, canes again have to be adjusted. Remember, wrist creases is where the cane handle should be aligning with. Again, same thing, always at 15 to 30 degree angle. And remember, the cane is going to be placed on the strong side, right? The patient will move this, so it's going to be sort of like the 2-point gait. The patient's going to move the cane and the weak side forward together, and then they're going to move their strong side. So that's cane walking. Cane is always going to be on the stronger side because you want to make sure that they have a good support on that. Cane is going to be on the stronger side. And then you're going to move the cane and the weaker foot forward together. You're going to move them together to make sure that you have a good support, followed by the strong same. Remember the same thing with your up and down the stairs, right? The patient's going to move the good leg up, followed by the bad leg and the cane, just like when you did crutches, right? Same thing with the down, right? With the down, you're going to move that the bad leg and the cane down, followed by the good leg. Okay, same thing. Okay, no, nothing really changes on here with the up and down the stairs. And that's it. That's really the big thing about crutch and gait walking in terms of assistive devices. This is a sort of a heavily kind of a crucial, important information to know that you might be tested on in terms of all those different things. And that's really it for your crutch, cane walking, all those different kind of mechanisms that are involved, splints, braces, and all those, and possibly some pediatric conditions we covered. We covered on client teaching about positioning. Remember, 2 to 3 finger breadths between the axillary area, because otherwise it could end up causing nerve damage. We want 30-degree flexion with crutches, at least 15 to 30-degree flexion with all the other things like walkers, and we're talking about elbow flexion here, okay? The elbow should be slightly flexed like that. All right, so that was it for our assistive devices. I'm going to go ahead and come to a stop right here. And just stay tuned for another one that's coming up. So this is a second part of it. This is a 2-part series.